Enoxaparin, also known by the trade name Lovenox, is an anticoagulant medication derived from heparin. It is created by removing low molecular weight fractions of heparin. Enoxaparin potentiates the inhibitory effect of antithrombin on factor 10A in thrombin, but enoxaparin is less likely to inactivate thrombin, producing a more stable response than heparin. Pharmaceutical scientists derive the medication from heparin by taking the most important components from heparin to create enoxaparin, so it still prevents the blood components that cause platelets to stick together from forming. This created a less risk of bleeding. When a client gets injured under normal circumstances, the particles work together to form a scab and protect the injury. Enoxaparin will not thin the blood as much as heparin, making it safer to use. In the risk of an overdose, the reversal agent protamine sulfate can be used to neutralize enoxaparin. Enoxaparin, or Lovenox, is used to prevent the formation of thrombi, more commonly known as blood clots. Thrombi that develop in the deep veins of the arms and legs are called deep vein thrombi. Blood flow can cause the thrombi to break away from the wall of the vein and travel through the venous system and ultimately land in the lungs. When a thrombus becomes dislodged, it becomes known as an embolism, and when it travels to the lungs, this is known as a pulmonary embolism. Enoxaparin can be used to prevent the development of deep vein thrombi or pulmonary embolisms in clients who have recently had surgery or clients who have been hospitalized and are less mobile than they normally are. It can be used in conjunction with aspirin to prevent ischemic complications from unstable angina and non-ST segment elevation MIs, as well as the treatment of acute ST segment elevation MI, when used in conjunction with thrombolytics or percutaneous coronary intervention.
Bridge therapy, enoxaparin, warfarin.
When used for the treatment of deep vein thrombosis and/or a pulmonary embolism, enoxaparin can be used in conjunction with warfarin. This type of treatment is called bridge therapy. Medications like warfarin also prevent the formation of thrombi, but it takes much longer for the medication to build up in the body to have a therapeutic effect. Bridge therapy refers to the overlap of short-term anticoagulation treatment, in this case enoxaparin, and long-term coagulation treatment like warfarin. Overlapping the treatments protects the client from more thrombi formation while allowing the warfarin to reach its therapeutic level in the blood. Healthcare providers can determine if a client's blood has therapeutic levels of warfarin by checking a lab study called the International Normalized Ratio, or INR. INR test measures the time that it takes blood to form a clot. Therapeutic levels of warfarin produce an INR ranging from 2.1 to 3 within 3 to 5 days. Enoxaparin and warfarin are overlapped for at least 5 days and until the INR has measured for more than 2 for at least 24 hours. Once this happens, the enoxaparin is stopped and the warfarin continues. The adult dosage of enoxaparin for the treatment of DVTs and PEs is 1 mg per kilogram every 12 hours for outpatient clients, 1 mg per kilogram every 12 hours, or 1.5 mg per kilogram every 24 hours. In both inpatient and outpatient clients, bridge therapy with warfarin should be initiated within 72 hours.
Administration. Subcutaneous injection.
Enoxaparin is administered as a subcutaneous injection at least 2 inches from the umbilicus or belly button on the anterior lateral abdomen, which is also known as the love handles. Pre-filled syringes of enoxaparin come ready to administer. Simply remove from the packaging, clean the selected site with an alcohol pad, and allow to air dry or dry with a clean gauze pad. Once dry, pinch the skin and adipose tissue of the selected site between your thumb and forefinger and insert the needle at a 90-degree angle. You may then slowly push the plunger on the syringe, injecting the medication. You do not need to aspirate. The pre-filled syringes have a safety mechanism that pulls the needle out of the skin and into the syringe once the plunger is fully depressed or pushed down. This helps prevent accidental needle sticks. Once the safety mechanism has been activated, place the syringe into a puncture-proof container like a milk jug and gently wipe the site with a clean alcohol pad. You may apply gentle pressure if the site is bleeding, but do not rub or massage the site. Be sure to alternate sites with each injection.
Side effects. Bleeding.
Common side effects of enoxaparin include bleeding. This includes bleeding gums, nosebleeds, bruises, blood and stool, and difficulty stopping bleeding from small injuries. Using a soft toothbrush will help prevent bleeding gums. Black tarry stools are an indicator that there is blood in the stool. Clients who shave should use an electric razor to prevent injury. Other common side effects of the medication include anemia and injection site reactions such as redness, irritation, and pain at the site of the injection. If bruising occurs at the injection site, massaging the site with an ice cube prior to administration of the drug may help. It may also help decrease pain or discomfort from the injection. Less common side effects include thrombocytopenia, constipation, alopecia, hyperkalemia, and urinary retention. Clients experiencing any of the less common side effects should report to their healthcare provider.
The healthcare provider will monitor labs such as CBC, platelet count, and occult stool to look for signs of internal bleeding and anemia. A decrease in hematocrit can indicate a potential bleed. APTT levels are not typically monitored with enoxaparin, but may be necessary in clients who are obese or who have renal insufficiency. Other lab tests may show an increase in potassium, AST, or ALT levels. The client should notify their healthcare provider if they have any head trauma or injury while taking enoxaparin, or if they get a large injury they cannot get to stop bleeding. The client should also notify the healthcare provider if they have a significant bruise or bruises that are unusually large in size, and if they experience any dizziness, itching, rash, fever, swelling, or difficulty breathing. The client should not take any aspirin, naproxen, or ibuprofen while taking enoxaparin to reduce the risk of bleeding. The client should know to report that they are taking enoxaparin to all healthcare providers and dentists. It should also not be taken at least 24 hours prior to surgery.
If a dose is missed, it should be administered as soon as possible. In the case of an overdose or significant bleeding occurs, protamine sulfate may be given as a reversal. 1 milligram of protamine sulfate should be given for every milligram of enoxaparin given, and it should be administered slowly over 1 to 3 minutes. No more than 50 milligrams should be administered in a 10-minute period.
Caution, contraindication.
The risk of bleeding may be increased if the client is using other drugs that affect platelet function in congregation, such as NSAIDs, other anticoagulants such as warfarin, antiplatelets such as aspirin, thrombolytics, dipyridamole, abciximab, eptifibatide, tirofiban, taclopidine, dextran, and some penicillins. Enoxaparin should be used cautiously in clients with severe liver or kidney disease, uncontrolled hypertension, retinopathy, recent ulcers, bleeding disorders, women less than 99 pounds or men less than 125 pounds, malignancy, geriatric clients, and clients who are pregnant, women who are breastfeeding, and pediatric clients. Extreme caution should be taken in clients who have bacterial endocarditis, GI bleeds, clients who have had recent CNS or ophthalmologic surgery, a history of thrombocytopenia, and patients who have had a recent spinal or epidural anesthesia. It should not be used at all in clients with an active major bleed.
It is important that a client with deep vein thrombi or pulmonary embolisms follow the treatment plan created by their healthcare provider. When a DVT develops, it can cause the walls of the vein to stretch due to the pressure of the blood below the clot. Once stretched, the valves of the veins that generally close to prevent the backflow of blood through the circulatory system are no longer able to fully close. This results in complications such as venous insufficiency. Clients with venous insufficiency have a difficult time returning blood to the heart. This leads to blood pooling, especially in the lower extremities. The human body carries about 75% of its blood volume in its veins. A client with venous insufficiency may find that the pooling of the blood in the lower extremities reduces the amount of blood flow that can return to the heart. This, in turn, reduces the amount of blood that is oxygenated and sent back to the body. Oxygenated blood provides the body's organs and tissues with oxygen. This is called perfusion. Without oxygen, the tissue and organs can dysfunction and cellular death can occur. Another side effect of blood pooling is that stasis blood is ideal for the formation of more clots. These clots may make it out of the lower extremities and travel to the lungs, resulting in pulmonary emboli. A pulmonary embolism can also cause perfusion issues. The blockage it creates in the lungs increases the alveolar dead space and interferes with the exchange of oxygen and carbon dioxide in the lungs. Ineffective gas exchange means the blood in the lungs are not getting reoxygenated effectively and re-enters the body without adequate oxygen to properly perfuse the body's tissue and organs.